as I told yesterday, these 3 days we will be talking about various initiatives and various issues in public health. Yesterday what was the focus? It was technology. Okay. So, how technology can transform public health, but there are issues in that which should be talked about. So, overall we can say that technology can increase access, reach, etc., but how to actually implement that? When you start implementing those things, there are some issues which you should be talking about. So, yesterday's focus was on technology and its role in public health, and what are the challenges, what are the issues in implementing those technology solutions. Today's beginning we will talk about Gujarat government's initiatives in public health. Largely, if you see, there are two aspects. There are some central government mandates which come, which are largely derived from the World Health Organization, SDG, etc., and there are state specific issues. So, for example, Chhattisgarh issues will be very different from Gujarat issues and UP or Bihar issues. It all relates to demographics, environment, sanitation, public health, or other aspects of public health including education, etc. So, what we have thought is we will touch upon two different states, different in terms of geography, also different in terms of per capita income, the age. So, Chhattisgarh being a new small state with a different set of demographic and socio-economic aspects as compared to Gujarat. So, today we will listen from Dr. Jayanti Ravi about Gujarat state. Tomorrow there will be a panel in the evening about Chhattisgarh. Okay. So, these two states perspective we will listen to. Yesterday we began with the central government's perspective, which was Niti Aayog. After today's introduction by Jayanti Ravi about the Gujarat state's issues and the initiatives which they have taken, we will talk about a burning issue which is violence against doctors. So, violence against doctor has been our focus of research in this center for last 2-3 years or so, and we have made a movie which will be which we will run through you. It's a small movie, so don't worry about कि हम आपको बहुत bore करेंगे. It's a 12 minutes movie. We will run through that movie, and then we will have panel from Indian Medical Association, Ahmedabad Medical Association, faculty from IIM Ahmedabad who has been a police officer earlier for long. He was an IPS officer. So, their perspective and the faculty and the other people will be present. Okay. So, the movie's director, Mr. Gautam Swanti, is there. He will initiate the proceedings of that session. Okay. After that, we will have lunch break, paper sessions, then slightly late lunch break, and then we will board a bus to Gandhinagar. So, all of you are welcome to come to Gandhinagar. We will go to IIPH. It's a beautiful campus, not as beautiful as IIM Ahmedabad, but but quite beautiful, but quite beautiful. And I have to say that, loyalty. And after that, there will be a session on incubation, technology, and entrepreneurship in healthcare. Around session on, and that is sponsored by Nidhi TBI. After that, we will come back, and then you are free. Okay, for today. Tomorrow, when we come back, we begin with a keynote address by Dr. Arvind Srinivasan. Now, you will think that when we are talking about public health, why to call a person who is from private healthcare sector, almost private, you can call it. It's a privately owned trust which runs Arvindai. But if you see the scale of Arvindai, they actually take care of around 7% of India's ophthalmology care. Okay, so that scale, when a trust reaches, it has to work with government. Otherwise, it is very difficult to reach that scale. For example, getting land or opening a hospital. So all of those decisions, how they work in tandem with the government, needs to be highlighted. Also, Dr. Arvind will talk about their perspective, that is private hospitals or trust hospitals perspective on their contribution to public health, and specifically related to ophthalmology. But you are fortunate to listen to him you will be fortunate to listen to him alive, means face to face, because his understanding of scaling up and his understanding of the issues in public health, not related to ophthalmology but in general, and working with government. So now these three topics are very diverse, and I would urge you to ask several questions to him before he goes away. Okay, so but there is a time constraint there. There will be only 15 minutes before he has to leave, because his flight is from Baroda, so he will have to travel 2.5 hours. We can't make him stay for question answers. So what I would suggest is, if you can give some questions in writing, we will give it to him as the talk is progressing. After the talk, we may select 4 or 5 questions which he will answer, and then we will have to let him go. Okay, that is problem, because there was no Bombay flight tomorrow afternoon. Means Sunday afternoon there is no Bombay flight from Ahmedabad. Okay, so only in that session we will have some restriction in relation to your asking questions. So we would not 1 or 2 questions we may take from the audience, but I would request if you can note down the questions and give it to some moderator, maybe Professor Mavlankar or Vishal will be there, I don't know. But there we would like to restrict the time of question answer to a maximum 15 minutes. Okay. And after that we will have a panel discussion on leadership in public health. So I would like to qualify something here, and that came out from one of the panelists. When we talk about public health, it is not only about programs like blindness control program or tuberculosis control program, no. So that public health, actually I should have written public health delivery systems. So it's my mistake, I did not mention the full. I thought what is my understanding is always understanding of the world, which normally people think, but that's not true. So that is leadership in public health delivery system. So for example, when we run large hospitals, say Arvindai, or large institutions like government hospitals, BJ Medical College for example, it's not only about clinical care, but it's also about how do you manage your doctors, frontline staff, purchase, supply chain, etc. So how these things become very critical when you are in an admin cum clinical role. In most of the hospitals you will find that the superintendents are specialists, they have been in the hospital for a long time. How those roles change or expand when they go up the ladder, and the requirement of work changes drastically. But is our training system of the hospitals or available training systems like IIM Ahmedabad, etc., are those systems catered to the need of those changing roles? That is what is the focus of the session on leadership in public health. It is not leadership in public health, it's my mistake, it's leadership in public health systems or public health delivery. Okay, so public hospitals, so the focus will be on public hospitals. So that is why the public word is there, because those things are also required in private sector. Okay, but there are some issues, limitations. For example, in private sectors you can employ a doctor and give variable salary. One doctor gets much more than another doctor, but in public systems, public hospitals, you are not, there is a band in which all the doctors are fit in. So whether you are physician or surgeon or cardiac surgeon, you are in a band, and though that band will determine how much salary I will pay. In private healthcare systems, you can design different performance management system for different organizations within the whole umbrella. For example, Arvind Chennai can design a different system as compared to Arvind Madurai, or a hospital can design a different system for cancer unit versus multi-speciality. But it's not so in public systems. So there are restrictions in terms of latitude which the management can take. That is why the training requirements of public health system delivery mechanisms like hospitals, CHCs, PHCs, district hospital will be very different as compared to private health. I will do only cataract. You can't say that. So you have to follow the mandates with the central. In the last panel is on innovations in public health, where we come back. Today we start with Gujarat, tomorrow we end with Chhattisgarh. Now, one thing which I would urge you to ask, and that panel can extend because we end at 4, but you can extend that question answer. I would urge you to inquire about how these states are different, because today you will listen to Gujarat, tomorrow you will listen to Chhattisgarh. You should inquire about how these states are different, why it is scalable, why the Gujarat model or Chhattisgarh model cannot be replicated even in the neighboring states many times. Okay, not forget the states, districts. Okay, so one model in one district may not be replicable in another district. So all of those issues are very pertinent to public health. Okay, so those things we will discuss. I would also like to thank publicly HCG hospitals, and Dr. Bharat Gadvi will most probably be here at 11. The movie has been made by us, but the whole support system, everything support, means from the heart to the soul, came from HCG hospitals. It is very difficult to portray my hospital with name when a violence incident has taken place in my hospital, and I am agreeing to put it in public for viewing. Okay, so I would have lot of respect for Dr. Bharat Gadvi and the HCG hospital in general for such openness in allowing us to shoot with name, no blurring, everything which has been depicted. What we plan is we would use that to generate in the long run. We will use that to generate awareness about this issue at a large scale. Okay, so many times you may not be attending one session and maybe having extended tea breaks, etc. Don't worry about anything. Everything is being video recorded. You will get in email or in WhatsApp all those recordings. All the PPTs will be there and they will be sent to you, but you can see the video recordings in any case. So parallel sessions are also video recorded. If you want to listen to 2 papers simultaneously, you can go back and listen to them at your leisure time.
And would you be sharing a total list of participants with their, like, the particular thing only has the name and the paper name, but we don't know where they are from, right?
So,
maybe a participant profile or something, like name ke saath.
So what we can do is we can in the WhatsApp group you can share your own profile.
That is very difficult.
Difficult?
But just, you would have a list.
We have a list of name and the money they paid. The bank account, yeah, we can share the bank account details. So no, we will try. We will try. What we can do is we will keep a paper here, and all of you can write that your own, which institute you come from and what do you do, those things, no?
Yeah.
So we will.
Just that. Like if I vaguely remember, okay, now here I have someone. See, I was interested in one somebody, but I don't know from where that person is. So even if I want to later on connect to that person, I may not have. I would have to probably look through all the video recordings.
No problem. So we will do that. Okay, we will do that. So it depends upon you. If you enter your data, then we will share it. So data in is data out. We can't force somebody, but whoever puts in the data, we will share. Okay, and it will be shared. So if you put in, it's a consent that it will be shared. From yesterday's session, I become very afraid about sharing data about anything, is it not? So any questions about, apart from this list which we need to generate, any other thing which you would want organizers to do apart from spending money which we don't have? Means any processes or any issues which you want to sort out which does not require money, we are open to address those issues. So this does not require money, this we will do. Anything else? Nothing. So we are all set, and we will wait for Dr. Jayanti Ravi. She will be coming by 10:30. She said. I am getting a phone call. Maybe she is already here. Good morning, everybody. And as we had discussed, today we have Dr. Jayanti Ravi, who will be talking about the initiatives in state of Gujarat with relation to public health aspects. Okay, we welcome Dr. Jayanti Ravi to start her address.
Thank you. Thanks, Rajesh. Thank you so much. Good morning. I'm very happy that we're all here on the second day of the healthcare management services, the advances that have been made, this special two-day conference that has been organized. And I had put together a few thoughts today and just wanted to share it. I see a lot of students here. I see people connected with public health. And Dilip Bhai Mamlankar Sahib did mention that yesterday too, it was quite interesting. You had a lot of deliberations and so on. So I'll keep it a little focused on what we in the government are trying to do and what could be the role of the private sector too. But would certainly look forward to more of an interaction questions from you. So maybe I'll take about 10-15 minutes and then another 10-15 minutes for your interactions. So we are actually trying to look at the landscape of health in a slightly more holistic way, not just in one dimension, but in several dimensions. So the first dimension is about really trying to see how public health is connected to tertiary healthcare. So this whole continuum of care. You often find that the screening that happens, the kind of awareness that happens, the kind of public health facilities that exist when we refer to places like the primary health centers, sub-centers, and slightly next level of facilities, secondary care like the CHCs and so on. There's a lot of disconnect between them and the tertiary care. So one of the things that we are very actively trying to do this time is to see how we can, in letter and spirit, bring about this continuum of care. And you'll all be very happy to know that one of the very important transformatory initiatives that the government has taken is something called Ayushman Bharat. And Ayushman Bharat has broadly two broad branches. Are you all familiar with them? So one is, of course, the health and wellness centers, and the second is what is called Pradhan Mantri Jan Arogya Yojana, where you're basically giving people the power of choice. They get enlisted as a person who has this golden card of the Pradhan Mantri Jan Arogya Yojana, and they can choose which hospital they want to go to for any problem, any tertiary care condition that they may have. I'll just take this call if it is. Hello? Yeah? Yeah. So I think I'll put the phone on silent so that for some time we're not disturbed by it. So coming back to this whole thing of Ayushman Bharat, as we said, there are two branches, the health and wellness centers, and then of course the Pradhan Mantri Jan Arogya Yojana, which is about giving people choices to go to tertiary care institutions. Now when we come to the health and wellness centers, you'll be happy to know that so far the emphasis was more on what? Reproductive, child health. And it's plausible because when you have limited resources, you want to spend your resources on something that's probably a more important priority on saving mothers, saving babies. But now you also find two interesting things happening. There is a disease burden shift. You find that there is a shift in terms of from the deaths that occur due to other causes, it's moving more towards deaths which are causing due to NCDs, which is more a lifestyle issue as well. And it's also probably, so India too in a way is mimicking the developed countries, and therefore the idea was that in the health and wellness centers we'll move away from just looking at RCH. It doesn't mean move away from it, but move away from only looking at it to looking at other things as well. And so we've got about 12 different segments or areas that we look at in addition to reproductive, which includes reproductive childhood, which are about child health, which are about 7 points. So this includes even things like the NCDs, non-communicable diseases. It includes ophthalmic, ENT. It also includes palliative care, elderly care, and then it also has things related to mental health, which is also, as we all realize now, becoming very important. So it's looking at all of these other aspects. And another area which it does include and which is very important for Gujarat is this whole issue of dental health. And given that the head and neck cancer incidence in Gujarat is very high, particularly in places like Saurashtra, where there is a lot of consumption of smokeless tobacco, gutka and pan masala and so on. And therefore, that also becomes very important. So first of all, we look at this continuum of care. And as we speak today, we have about 9,000 plus sub-centers and as many as 1,600 primary health centers. So they are all in the process of getting converted from just being centers which would treat disease and illness to becoming centers of health and wellness. So not only are we looking at all the aspects, as we mentioned, not just reproductive child health, others, but it's also looking at the preventive and well-being aspect as well. So we are also giving a lot of emphasis on other alternative practices such as heartfulness, Reiki, yoga in a very big way. Gujarat has been taking the lead in it. And you'll also be, some of you may not be aware of the fact that we have also taken a lead in trying to synthesize the other alternative systems of medicine with allopathy. We've tried out, it started as a small experiment in October 2018. And it's about more than a year now, and we have now included it and incorporated it in all the routine training of our community health officers, which is IIPH is also one of the key institutions implementing this. In that, we've brought in a module called Samanvay. Samanvay was a program where we tried to look at other practices such as Ayush and see how that could be synthesized with the conventional way of treating patients only using allopathy. This was done with the help of a Ayurvedic college in Nadiyad called the KS Institute of Ayurveda. and this has also been, it is also being documented by the Karamsad Medical College, Pramukh Swami Medical College, and so on. So these are some of the things that we're doing: heartfulness, yoga, Reiki, Eat Right, Fit India. So all of this is also a part of the preventive and the health and well-being part of our focus, which is now, as I said, Ayushman Bharat is increasing from just treating disease and illness to really making sure that that 80% of the population, which is perhaps not yet morbid, not yet sick, but we try and ensure that they're also taken care of, so that the burden of these 20 also, you try and prevent them falling into the trap of 20. Now, similarly, another very interesting, when we talk of healthcare management services, so one more thing we have tried to really do very effectively is the use of technology for managing and for getting granular data on each and every person who is approaching us, every household. So this is something phenomenal that has happened. I would call it a big revolution in Gujarat. So we have been the first state to do this on a very comprehensive scale. We have rolled out something called the Technology Enabled Community Health Operations Initiative. It's called TECO. That was the name given by the Honorable Prime Minister when he launched this. And it's very interesting that this began as a very small pilot way back in 2009, and then it went on to become a little implementation, you can call it a proof of concept across 3 districts, along with an NGO partner called Seva Rural in Jhagadia in 2013. And then there was a randomized control trial based on which the results were found to be overwhelming, and it has now been rolled out across the state of Gujarat for the last nearly 3 years. And what we find very interesting in this is that today I would like all of you, I mean, I'm sure you have a bunch of apps that cloud your mobile screen. You may like to look at another app. If you go to Google Play Store, or if you went to the iPhone, the iStore, you can download something called State of Health Gujarat. You can write it down, State of Health Gujarat. And if you download this, you can actually figure out, if you want to know how many mothers are anemic, or how many pregnant mothers unfortunately died, or how many babies have got immunized, which is it's a more positive thing to see. What is the sex ratio? You can actually drill down. For the entire state, you'll have the aggregated data. You can drill it down to the level of every district, every corporation. You can go to Ahmedabad city and see what is the sex ratio for Ahmedabad corporation as a whole. You can further choose any of the primary health centers there. You can get what is the ratio, or what is the number of babies that have been immunized, all these parameters, including severely, acutely malnourished babies as well, all of this data. And further, not only do you stop at the PHC level, you can go to the level of the ASHA, and then finally right up to the household level. And for those of us, because we don't want to compromise on the privacy of data, but those of us who are working in the government, we also have access to actually knowing who is this baby which has not been fully immunized, which are the vaccinations that are left. And the story doesn't stop there. We also have the name of the FHW, the female health worker, or the auxiliary nurse midwife, as we call her, or the ASHA. They're all listed there, the names and their phone numbers. So we can actually, with the click of a button, talk to her or talk to the person concerned. If it is something to do with NCDs, the non-communicable diseases, we can directly speak to the concerned MPW and ask them, why is it that this baby is left out? What is the problem? And I'll tell you today that it's been a fascinating experience in the last several months, where I have been on a daily basis talking to ANMs across the state, talking to ASHAs, and you see the resilience, the confidence with which we've seen them respond back, talk to us, is also very heartening. Recently, about 2 months ago, we were on a flight back from Rajkot. We had our health minister and also the union health minister. He was traveling back. So when we explained this to him, he actually spoke to one of the female health workers in a district called Banaskantha, and this must have been around 8:30 in the evening. But I was very surprised with the confidence level, in spite of not being so familiar in Hindi, she was able to converse with him in Hindi and explain various parameters which the Union Health Minister, who himself is a doctor, a medical doctor, he was talking to her. So this is something that we've done, and very recently there is a very reputed journal called PLOS Medicine. So we've also had, this right now, we all talk of evidence-based policy making. So there has been a randomized control trial, and there has been a full report on TECO also, which has appeared in this, which again gives a little shot in the arm. It gives us that confidence that we are really using evidence-based policy making and plowing it back. Now, taking this continuum of care method further, we also have a huge network. As we said, there are two branches of Ayushman Bharat. This is the health and wellness side, but there's the other side of it which relates to the tertiary health care, tertiary and secondary health care, because a lot of secondary procedures have also been included in the PMJ and the Ayushman Bharat there. So we have, as we speak today, 2,545 hospitals in Gujarat which have been empaneled, and it includes nearly 740 private hospitals too. And of course, we have all the government and grant-in-aid hospitals which have all been empaneled. So their citizens who have these golden cards, and even those who are enlisted or enrolled in the MA Mukhyamantri Amritam Yojana, which was again a very popular scheme of the Gujarat government, and the Ma Vatsalya scheme, they have all access to choosing to take medical care from any of these facilities. And as we speak today, Gujarat has the first rank in terms of the number of claims. We have 11.78 lakh claims nationally, more than any other state, and about 1,842 crore rupees worth of treatment is being given out, which only goes to show that we're doing two things. On the one hand, we're really screening each and every household, as we said, with the help of TECO, with the help of an app there also within it for NCD screening, the non-communicable diseases screening. We're actually screening and finding out anyone in every household who has these symptoms and these possibilities of having any of the NCDs and so on. Then they're next immediately pushed to the next level for screening, reference and so on. And then they choose actually to come and take. So the health-seeking behavior of people has also increased significantly. And that is why we also see, as we said, about 73 lakh people have taken the golden cards, and the number of claims, the number of people, that awareness of various health facilities that they are entitled to, that they can get, has also increased. So this is again a positive thing that we've been seeing. But as we get into this quantity game, it's very important also that we look at quality. And therefore, a big emphasis that is being laid by us currently is about really going in for quality certification, particularly the NABH, NABL. We're pushing this in a very big way, and also the National Quality Assurance Scheme, the NQAS certification also is happening very, very prominently. We have a certain program rolled out by Government of India called Mera Aspatal. How many of you have heard of this? I think a large number. So I'm very happy to share that Gujarat has gone ahead and aggressively got nearly all our hospitals enrolled in this Mera Aspatal initiative, which means that the public which comes to take any medical or any such treatment there has to give feedback on three important parameters or three dimensions: about the general cleanliness there, about the attitude of the staff, and the services that were given to them. So this is again, we find now it has been rolled out across the state, and we are trying to see that the quality of services, the attitude of the staff, the cleanliness of these facilities is also really high. And in this context, we have also gotten into several partnerships, and one of the important partnerships here is with Cisco Foundation. So we're really trying to train on life skills our nursing staff and all our staff. We've had 2 pilots. The results were extremely overwhelming. We find it extremely encouraging. And we're now more or less on the verge of rolling out a huge capacity building exercise, basically for life skill and attitude to medical a treatment. Basically, we want to make sure that the attitude and the human touch, this whole issue of empathy, how do you behave, your behavior with people that come in, it could be patients, behavior of a doctor, of a nurse, even of a janitor, a cleaning person, anyone in the government facilities, we want to make sure that your behavior with the patients is also, because that too is a very important determinant of how the patient heals and responds. So these are some of the things we are doing. And another very interesting area that might be of use to all of you is often we find that these tertiary care facilities, they're extremely crowded. Not very far from here is the Civil Hospital, Ahmedabad. And if you were to go there in the morning around this time, you'd find that it would be a big hive of activities with a lot of patients thronging there. And many of these patients are not those that really need tertiary care. The people who are coming there with ordinary fever, maybe a bout of loose motions with some other difficulties, and so on. So as we typically say, I'm sure you've heard of the triangle which is inverted. So to change this triangle and make this inverted triangle a proper triangle, one of the initiatives which I'm very proud of, and Gujarat has been the first one to take this initiative, is something related to midwifery. Because one of these verticals, or shall I say the segments where there's maximum traffic in all these tertiary hospitals, relates to the gynec department. See, that is one of the most crowded segments. So what we've tried to do is, instead of having everything getting escalated to the obstetrician and the gynecologist, we've tried to create a cadre of midwives. And this initiative of training midwives started several years ago. And I must say, IIM Ahmedabad too was involved in it. Dr. Dholakia sitting here will agree with me. It was probably done with IIM Ahmedabad and probably the Karolinska Institute at that time. But then these midwives were trained. But unfortunately, we didn't have a way of very, in a structured way, incorporating them. And because you see, sometimes these programs start and then you don't find that the program has been sustainably taken forward. So one of the things we did a few years ago is we took a decision to have these midwife-led care units housed in the same hospital. So the triangle continues to be an inverted triangle, but the idea is to wean them away slowly to the secondary and the primary healthcare facilities. But to do that, you have to build people's credibility, confidence in these midwives. So what we've done is we have these midwife care units right in situ, co-located in the hospitals, and we're finding that this is a great transformation that is happening across many hospitals of Gujarat. It's happening in Surat. Baroda is probably one of the main star hospitals in this respect. We have a very dedicated team there. So every day we get pictures of babies born. And what it has done is, not only has it crowded out the volume of patients going to the obstetrician and the gynecologist, because there is a triaging initially, and only those patients who don't need that kind of a very complicated, if there is a complicated case which needs the specialist to step in, that is kept aside. But all the normal, ordinary cases are being pushed or being diverted right there to the midwife located there. This is one side of the story. But the other thing which, according to me, is far more exciting is that we've also used this as an opportunity, because, as it is said, doctors tend to act, but nurses tend to wait, right? So there's a big difference, and this whole process of childbirth is a very, very normal physiological process. It's not a pathological thing. It's not a disease. And therefore, nature probably also requires that kind of patience and waiting, which, as an attitude, nurses are more inclined to be that way than doctors, who are more inclined to act. So what we have seen is, as a fascinating spin-off, another dimension of this is that now with these midwife-led care units, we've seen a big revolution in terms of various new methods. There are alternate birthing positions. Till now it was the lithotomy, which would be done almost in every case, but now I have a large number of cases in these midwife-led care units where we are seeing women giving birth in different alternate positions. It could be the squatting position, it could be on all fours, and so on. And again, equally fascinating is the fact that we are inculcating and really seeing this practice of physiological cord clamping. It's different, I repeat, physiological cord clamping, which is very different from delayed cord clamping. So what is happening is, and every day I get to see numbers of such pictures, because we have a very excited and a very energetic set of midwives across the state who are sharing all these pictures with us. We see the baby being delivered, after which, without the cord being clamped, the baby is immediately placed on the mother's abdomen, and it does what is called a breast crawl and slowly moves towards the mother's breast, which means that lactation also gets automatically facilitated. It gets started. You don't need to then later on struggle with this, because I think there's the natural tendency of the baby to seek to root for the mother's breast also happens. It can smell, as you know, the flavor bridge. It's one of the first sensations that the baby develops. And not only is that being done, we find that in a matter of 5, maximum 3 to 5 minutes, about 6-7 minutes in a few cases, the placenta too gets very, very normally, naturally delivered. So there's no pulling, there's no pushing, and the mother is kept in a very, the kind of violence of maybe even thought, word, and sometimes in very rare cases, unfortunately, which would really appall me, violence of action also that would happen in labor rooms. You're finding all that is now getting transformed into a labor room, which is almost a room of a lot of dignity, care, love for the mothers, with some very soothing music happening there. And we have all these nice gym balls, and we've got these various simple ladders and other equipment. And this is a big revolution, and I'm sure a lot of mothers seated in this room may also have loved to have their babies be born in such a way, had they had this choice at their time. So this is again another revolution. So coming back to the triangle and the inverted triangle, our dream is that just as we've tried this out on the vertical slice of obstetricians and midwives, if we can, and we're planning to do this for other nurse practitioners too. There are many professions, many such disciplines where a nurse practitioner can provide a lot of these skilled services under the guidance. And of course, given that the distances are not far away, even if we move them out now to a urban CHC, community health center, and if there were any complication or during the ANC, there's anything that requires the mother to be really escalated and taken to a tertiary care, obstetric, ICU maybe, and so on, that option ought to be there. But what is actually to be avoided is all the mothers crowding in on the obstetrician, which means that those mothers that really need, if it's a complicated case, that gets crowded out, that gets lost. And at the same time, cases which don't really need such a very complicated treatment can be handled very, very skillfully, very nicely, naturally at the hands of a midwife, who's doing a wonderful job too. So the two can coexist, knowing clearly well that there's a demarcation of roles, clarity of functions. So looking at the success of the way midwifery has worked, and in inverting this triangle, or the triangle piece is yet to fall off, but at least we are making sure that there is a crack coming there, and we are trying to demarcate the two roles. But this will now also happen in other fields, with nurse practitioners coming in for other areas under the overall support of the doctor. And we do hope that these are the things, when we talk of advances in healthcare management services, I think we need to really innovate and look at better ways of delivering services. We need to see how is it that we can provide these services with greater empathy, greater care, dignity for the patient, and the patient really feeling a sense of, as it is, they would be, I guess, in a lot of pain. Whenever one enters a hospital, it's not a joyous picnic that one comes to. People come there because there is a condition. So if we can at least help mitigate that pain, and if we can help do something to make them feel better and go back with a lot of faith, trust in our facilities, I think it would be a big step ahead. So very happy to be with all of you. So these are some of the initiatives that the government is doing, and I do hope that we can hear and have some of you suggest good ideas, partner with us, take up small pilots, projects, and if you're from educational institutions, we would really like all of you to come and document some of these things that we're doing, see what are the other course changes that can be done, what has worked, what has not worked, etc. It would also give us a lot of insights. Thank you. Are there any questions or something?
Any questions?
Hello, ma'am. Good morning. Arun Patro, I work with IQ. You spoke about the continuum of care, and that's absolutely critical. We talk a lot about convergence across departments, but this is actually an area where there is convergence required within the health department itself. Could you please elaborate on the steps being taken to improve the continuum of care in Gujarat?
Shall we take a few more questions and then address them together? Continuum of care within the government, the silos within the government, yes?
Good morning, ma'am. My name is Dr. Gunjan and I work with IMA. My question would be, now that you said that we have a non-communicable disease screening going on, and we understand that the geriatric population is increasing given the improvement in the health care. So do we have any plans of any specific geriatric clinics being set up, for which people don't necessarily have to go to the hospitals per se, which can be another part of vertical or the inverted triangle to be corrected?
Hello, madam. I'm Amar. I work with the Tata Trust, and we work on urban health. So, we wanted to share a thought with you that how Gujarat is looking at tremendous urbanization that is happening. There are so many cities, so many peripheral agglomerations that are coming up, and what kind of inter-ministerial or interdepartmental collaborations Gujarat government is taking so that comprehensive primary health care can be provided.
Is that all?
One question I had about this interesting scheme.
What is
you
your name?
Samanvay. I'm Dr. Amit. I'm co-founder of Onco.com. I'm an oncologist also. So Onco.com is an early stage startup. We are in growth stage. So about this interesting program called Samanvay you mentioned, where allopathy works with Ayush. So how do you? That's an interesting thing where we have an opportunity to generate credibility about Ayush practices by bringing in evidence-based research practices in Ayush protocols, so that more credibility can be generated. So do we have anything related to that? How do we generate credibility about Ayush while working with allopathy?
Ma'am, just to add to that, you spoke about having...
Your name again?
I'm Arun Patro. Yeah. So you spoke about evidence-based decision making, but at least in healthcare, right now we stop with inputs and process. We really don't move to outputs and outcomes. So is the Cisco Foundation helping you do anything over there or anything else?
Good morning, ma'am. I'm Dr. Mona Desai. I'm president of Ahmedabad Medical Association and a pediatrician and a neonatologist by profession. Ma'am, I just wanted to know whether we have specified clinics for antenatal care, like teaching all the young mothers about nipple care and all. And most important, after the baby has been born, I think we are not even training them how to take care of a baby, how to feed them, how to nurse them. So sometimes, they all make so many mistakes. So, and secondly, the health of the mother. Because once the baby is born, none of the gynecologists or anybody even advise them to take iron or calcium or protein or what diet they should take. So we have those age-old myths which goes on in the house. So maybe I think it is time we should have a specified postnatal clinics also for mothers, where we can train them for their own health and the health of the baby. Thank you.
Good morning, ma'am. My name is Chintan. I want to just ask, you have mentioned about the empathy and the dignity of the patients, and it is an important part for the healthcare provider that they treat the patient with empathy. So I just want to know that any formal training for the healthcare providers for the emotional intelligence or the something like that they can understand patients' need very well. Any initiative for that is going on or not? Thank you.
I'm Dr. Nitin Shah. Only thing I want to know about the thalassemia screening. Now latest thing is screening of that children and recently born babies. Second thing, I've started International Institute of Holistic Health Care and Ayurvedic and homeopathy, allopathy, yoga, lifestyle management. I want your advice more about the holistic health care. Right, thank you.
Good morning, ma'am. I'm Gayatri. I'm from Sept University. I wanted to understand that you mentioned the State of Health Gujarat app. I'm assuming it is collecting data from this TECO that you have created. So what were the challenges involved in implementation of TECO across? Because if you're going right down up to the A&M level, I'm sure there must have been challenges in implementing and making them learn the usage of this technology.
Lots of challenges.
Yeah, right.
Good morning, ma'am. I'm Nupur. Basically, I'm a physiotherapist, but right now I'm pursuing my master's in hospital administration. So I just wanted to ask you that you mentioned about the program Samanvay, with which you have included Ayurvedic. Like for antenatal care in reproductive and child health, I wanted to ask you, are there any programs which are related to physiotherapy that are given to the mothers? Because in today's fast life, there are like many problems which the mothers are facing. That's my question. Thank you, ma'am.
It would be amazing if you can answer all those questions. My name is Ade. I'm a urologist and medical manager in the UK.
Which country? Where are you from?
UK. Working.
I spent my childhood in Nigeria. So.
Well, I'm originally from Nigeria.
Okay.
We may have been neighbors then. Who knows? I had the privilege of attending the Emergency Response Center over the past week, which just blew my mind in terms of the infrastructure there, the commitment, the staff, the quality of the service that I see, access times to emergency services, specification for women who need to access help, even for animals who have been hurt, and coordination of all that. And the response times, as well as the difference it seems to have made to the community. And along with that has been the expenditure. So the question is, how do you seek to maintain that expenditure? Because the more you provide, the more expectations increase from people about the quality of the service. So how do you maintain that expenditure? And how do you roll that same quality of commitment and excellence in other areas of healthcare?
Hello, ma'am. I'm Dr. Rohan from V School, Mumbai. Ma'am, you mentioned that tertiary care, there is a high footfall in tertiary care hospitals. So has Gujarat government taken any technology-based initiatives to make the waiting area more productive and give a better patient experience?
Hello ma'am, I am Purva Jaswal and I am MPH student at IAPHG. And my question is like, is there any provision of dedicated public health cadre you're planning in for the Gujarat government, like other state, Tamil Nadu has done this. So is there any dedicated public health cadre to be coming up in future? Thank you.
So shall we start with Purva? We'll start reverse order. And so first of all, the answer to your question is yes. So whichever is a multiple choice, we'll finish it. We've actually designated this whole set of people, we now call them public health officers. That has just happened. The RRs are out and the promotions, etc. will happen soon. It's an internal thing, but I'm very happy. So we do have a cadre. But one of the things which Tamil Nadu has done, which I'm also very keen on doing here is, it may interest all of you, that Tamil Nadu doesn't have a lateral entry for the tertiary care later on. So it's the same primary, the public health officers who are given in-service opportunities, just as we in DNB, etc., have an opportunity for doing postgraduate in-service. And it's the same person who then gets, over the years, becomes specialized in whatever pediatrics, etc., and joins. And the advantage there, we probably need to have a blended system where you can also have people entering laterally, but you should also have these people go up. Reason being, the person sitting in the civil hospital here will really know what it is to work in Dediyapada. What is the, Dediyapada is the name of one of our tribal districts backwards, to say that, that continuum of care happens when it happens here, in all the people working there. Otherwise, with bricks, you try and build but then bricks can very easily still become walls here. That was one. Rohan talked about tech-based, how do you use the waiting area? The answer is, partially, yes. We've done something very interesting. And we'd like young people like you to also help us in these ideas. One of the things I've been fascinated with in the last few years is we have a very large number of students, right? Nursing, physiotherapy, and the undergrad medical MBBS students. Now, even assuming that the MBBS students too, all these are clinical, basically they're all clinicians. They have to be actually dealing with patients, talking to them, touching them, taking measurements, etc., engaging with them. So one of the things we've tried out is we've looked at nursing colleges co-located with these big hospitals and involved them in the initial triaging. The students come there, they use this waiting time to take their BP, height, weight, name, and also fill out a form for Mera Aspatal, the technology thing. So the phone number, all of it. And you're also making things a little easier for the doctor, finally, because the volume is so high that the per capita time that the doctor is able to give is much less. So you don't want to waste her time, the doctor's time in, waste is a wrong word, but if you can slightly minimize the task. So that's the kind of thing we've done. But we would like to do more of it. So if you have some more ideas, happy to. Ade asked about the sustainability of the 108, 104. It's a fascinating thing. In fact, informally, it's also believed that this initiative alone had a very important role in terms of governments winning elections too. It's believed that 108 was such a popular scheme. It came to be known as, a scheme that this government, it was a very popular thing, and it is still very popular. And our Chief Minister himself daily monitors what is the kind of response time of these 108 ambulances. So between the time a person calls and the ambulance reaches, it's monitored very precisely. And we're also, so a question of how are we trying to have this reflected in the rest of our cadres in the rest of the hospitals. So we've got this time in the budget, one of the things we are looking at is setting up a cadre of practitioners, like we spoke about nurse practitioners, midwives. One of them will be emergency nurse practitioners. Because when they reach, you may do all of this and quickly take the patient to a casualty ward. But if the response there is absolutely lukewarm, if the people there aren't prepared, the doctor is still to come, 2 in the night, 3 in the night, it takes away credibility. So we want to have a cadre of emergency nurse practitioners who are available round the clock. And we are planning to take inputs from, and we regularly have training at, they call it the Advanced Life Support Training and BLS, ALS kind of basic life support and so on. So that was there, but that question does get me to think in terms of sustainability in the long run. We'll have to figure out how because it is a costly proposition too. So the government is pumping in a lot of money, and we're hoping that that gets sustained. So that is a useful question. Nupur asked about the Samanvay. Where is Nupur? Yeah, I think that's a very valid point, and you'll be happy to know that we're also doing something very interesting in the 1,000 days window. You're all aware of the 1,000 days window. 1,000 days starts from the time the mother conceives the baby, because I'm sure you've heard of this. I've said this on various fora. A Nobel Prize in economics from the University of Chicago actually showed that every dollar spent in the 1,000 days gives a return of nearly 48 times. So 1 rupee gives a return of 48 times, whereas that comes down this way as a graph. So much later, if the government were to spend money on education later, higher education and so on, not that one is against CEPT or anybody, but the return for that money is much less. So the maximum, so the antenatal clinics, Munabin, the point you made. So that's a very golden window, that 1,000 days. So we're really trying to, we've done a lot of work on that in terms of mapping who are all the possible care providers who come in touch with the mother in that 1,000 days, starting with the community level ASHA, to if there's a complication, the mother would go to the next, escalated facility and so on, and all aspects, right? And it's more about, there are 100 billion neural networks that develop in the brain. Can you digest that? It's almost like 100 Indias inside the head of the baby getting formed. That is the kind of rapid pace at which neural networks develop in the brain of the baby. And these, very interestingly, your question is so right, they are not so dependent on the physical food that the baby has, which is through the mother, inside or later, 6 months. But it's more the stimuli. You give something different called cognitive nutrition. And what is cognitive nutrition? Question to you. One is nutrition for the belly, for the flesh and bones and whatever. So what is cognitive nutrition that a baby needs? Yes, but if we made it very simple, in simple terms, it's very simple. It's all how many stimuli, sensory stimuli, and therefore physiotherapy is very important. So smell, for example, if you expose the baby to a bunch of smells, then all the neural networks related to fragrance will develop. That's why traditionally, in homes, you probably had all kinds of smells. You didn't sanitize the home and say you'll only get to see Savlon smell. You wanted all the similarly sounds. You want the baby to hear different cadences, different types. I'm not saying loud alone, right? So very valid, and now in all our district early intervention centers too. So there's another little problem that's happening, that we are really, with the advances in technology, we're able to drastically bring down the infant mortality rate, which is great news. So from where we were, it's come down to half, and now in Gujarat, if you go by TECO data, we are even lower, which is wonderful. But we should also not lose sight of the fact that while we are saving these lives inadvertently, are we compromising on the cognitive development? There may be babies that are made to survive with surfactants and whatever. But is the cognitive, so are these babies who might then turn out to be autistic babies with CP, neuromotor impairment, and with in vitro, so many clinics coming up, we don't know the implications of all of this. And therefore, it's very important that we address, and so physiotherapists and other disciplines are very important, even the retinopathy of prematurity, ROP as they say, because with all these complications. So that's a long answer to a short question. Gayatri from CEPT, challenges in the implementation of TECO. Let me just say it in one word. We had a ton of challenges, if that, and I think in any implementation in the government there are, but this was even more special. It had a lot of challenges, but looking back, and I certainly plan to write a book on this, the challenges and whatever, there were many things here that happened, but nevertheless, I also feel very happy on, of course, the fact that it has worked. But one thing as a public, shall I say, administrator or a person who's working here in public administration, I really feel that this was a huge exercise, not so much in technology. It was a huge exercise in change management, right? You had to work on the mindsets of our force. We had 10,000 strong female health workers who had to, and many of them, the average ages were perhaps more than what is our age. They're probably all in their late 50s, 60, almost bordering 60. And for them to use this small toy called a mobile, and sometimes your finger doesn't, but I think it was a remarkable, and I take pride in the fact that while we tried to push this program very aggressively and did succeed in it, but I also feel very happy that we didn't have to issue a single suspension order. You know what that means? Punitive. We didn't have to throw out a single person. So I feel the power of, and that is also the message we want to give to people, patients. It's otherwise a dysfunctional. If I resort all the time to a suspension and a punitive action, that percolates, and in the entire hierarchical thing. So the last mile person would treat as shabbily a patient as they are, whether it's justified or not. So I think it also has a very deep satisfaction that one got out of this, that you dealt with this whole issue, but not by losing anybody or being, you were firm with them, disciplined. Being firm, being polite can go together. So that's something that we feel it's important. And today what's very nice is all our CDHOs, when they start their day, when you just look at this dashboard, has any of you seen it? You can see a very nice red, yellow, green, and we keep moving the bar of the green. So green earlier used to mean 70 plus. Today green is 98 plus. So we want to be absolutely not tolerant of certain things. There's something for us called data, what is it called? Data quality is a parameter that I get on my login. What it means is every day there are 15,000 outgoing calls from the 104, 108 and 104 sit together to, what's the word for it, to triangulate, to actually check. So we do outgoing calls to 15,000 recipients of various services. It could be an immunization, and check, did you get it? So if someone has lied and put in the data, that's not immediately shown that your data quality is not good. So we don't want to, because sometimes in this rush of getting things done, quality shouldn't become a casualty. So that is about the state of health challenges. So I'm planning to write a book, and I'll probably ask Gayatri for some tips sometime. Involved in it, excellent. Noted. And I shall come back. Okay. Then Nitin Bhai spoke of something fantastic, holistic health care and the thalassemic screening of newborn babies. Couldn't agree more with you. But the only feeling I also have is now thalassemia screening is done in most of the colleges, I guess in all the colleges of Gujarat. And if there's a way, I'm not sure we've succeeded, but if you can, Ashwini Ben, the IIPH team can take a lead in this. If we can do a counseling, it's difficult to prevent marriages of people where there is a very great probability of a thalassemia baby being born. Similarly for sickle cell. So for both of these, one of the things we want to do in the coming year is, just as we do a complete family health census, we also want to do a complete family health screening, testing. So it could be blood group and other things. So we're also thinking of sickle cell and thalassemia, at least in those pockets and those communities where it is prevalent. Having done that, if there is a way of discouraging adolescents in the marriageable age and educating them to avoid getting married, of course it's a very, very sensitive issue because it shouldn't create a taboo. The idea is not to isolate people who are, but nevertheless, so these are things we could work on. We'll be very happy to work with both of you and IIPH. Holistic healthcare as well. We would love to see how the Samanvay, I think somebody else asked for it. Chintan asked about this formal training for empathy and dignity. So the Cisco life skills training was primarily aimed on it, but we also have a fantastic institution which in the last 2 years has again is coming back to its glory. It was unfortunately, it had lost some of its glory because it didn't have a place to sit. This is the State Institute of Health and Family Welfare. We have now a fantastic body for it. I mean, a building with everything, all that in Baroda, and the team is doing wonderful work. It has a very good leader. And some of us, Dr. Dholakia and others, are also involved with it. You're most welcome. Where do you work? What do you do? All right. If you're interested, you could come sometimes, see what is happening, and also join as a resource person for some of these trainings, which you can do along with your job. So if there are people, because we are working on it, and the Cisco training, as I said, it's basically about this whole compassion quotient and all of that, because that's very important. Without that, we can't. Then Mona Ben spoke about something very important, antenatal care. I couldn't agree more with you, because I think this is because of the unfortunate divide between the gynecologists and the pediatricians. So the gynecologist believes that once the baby is out, my job is over. And but now, so we are engaging more and more with them. And I'm very happy to say that the current FOXY, All India Elect, FOXY is the Federation of Obstetricians and Gynecologists, Society of India, or whatever. So the current new president-elect is someone from Gujarat, and again a wonderful person, Dr. Alpesh Gandhi is the new person. So he too, so we've already started having conversations with the IAP, Indian Association of Pediatricians. We had Dr. Digant Shastri, who was there last year, and now there is a new person from Bombay, but also of Gujarati origin. So we are engaging with all these associations too, because in Gujarat, we still have about 60% of these deliveries happening in the private sector. There's only about 40 happening in the public sector. So just changing the public sector hospitals is not going to help. We have to all collectively. So we would be very happy if you can lead this, or you can play a key part in this. You were a part of, you are a part of IMA. But if we can all start creating more and more awareness, I think public is also aware, and so all these 1,000 days, these ideas. So if we can start with these practices, as we said, lactation immediately. Now that may not quite be very high on the priority of the gynecologist, because for them it's about how do I immediately stitch the mother back, and again needless episiotomies. I was going to come to that. You know what's an episiotomy? When the baby is to be brought out, sometimes you find that the space there is less, or I don't know if I'm technically explaining this properly. There's a cut which is given. Now, this is extremely rampant in some places, needlessly being given, which leads to a lot of other health complications, because women from rural areas, the hygiene, the cleanliness, the sepsis that you have to maintain, etc., gets compromised. So we're trying to say in the antenatal period, if she can be taught to do various exercises, including the butterfly exercise. So we are propagating all of that to see that the baby is able to be brought out. The baby is delivered very normally and carefully without much of a problem. So the answer to your question is we don't yet have specialized antenatal clinics, although the checking is there, and we are trying to inculcate as a part of TECO, care of the nipples, all of that for the mother, even while she's in pregnancy. So that is going on, but there is still a need to strengthen it. So we would like you to be, if you can come up, so as a part of the 1,000 days. So we've put all of those in it, but there's still a lot of work to be done in terms of propagating, and we would seriously like that. I didn't get your name from Amit. Dr. Amit spoke about Samanvay. So what we're doing is very interesting, and since Dr. Dhorakia is also here today, I'm going to mention it today. There's a meeting that's going to happen later today, and you may have to convey this to Dr. Veena Varalia as well. She wanted to know what we're trying to do is, just as we have the codification of treatment pathways. You see, if a person comes to two doctors in the public facilities, a primary health center A and primary health center B, with a common cold, ideally the treatment pathways should be similar. It should be the same. So we had, I think in 2015, done some fantastic work. Our state has actually come up with a compendium of various treatment pathways for a very large number of common and not so common diseases. But of course, after that, there have been some more exotic diseases like the Chandipura and Crimean Congo hemorrhagic fever, some new diseases also which come up, and now corona and COVID-19, as it is called, coronavirus. So of course, some of it is symptomatic, some of it can be treated, and so on. So these treatment pathways are all being codified and put in the form, and we are in the process of incorporating it in TECO, so that even that part of it is guided for the doctor. The doctor doesn't have to worry that I don't remember everything. Of course, at every stage, there will be a choice given to the doctor, because sometimes you must have that other option. Suppose you find there's something else in this case which wants me to take some other course of action. It's giving that choice, but otherwise for the mainstream, we are putting all that in place. Similarly, for Samanvay 2, we started this effort, as I said, way back on October 2nd, 2018 is when we launched it. And we observed, we found the result in terms of the satisfaction of patients, improvement in their parameters, all that has been it has been overwhelming. And there's a very committed person called Dr. Gupta, who is the director of this institute, Ayurveda Institute called the KS Ayurveda College in Nariyat. And this is incidentally a college which was set up by Sardar Vallabhbhai Patel. But it, as it happens, some of these institutions have their ups and downs. It's a fantastic private, it's an SFI institution, widely respected. They do a lot of research work with Germany and other European countries. People, doctors from there, MBBS doctors come here to learn. So we are working with them for about a year and a half, and with the Ayush Ministry at Delhi, Dr. Rajesh Kotecha and all of them. And the idea is to make similar treatment pathways, also codify it. With some choices. The codification doesn't mean that you tie their hands and say that this is it, but it's like a guideline which will help. So that process is also on, and all this, we would like to throw it open in the public domain as well, because the government, it's not about holding things close to your chest, but allowing and enabling everybody to use this. Urban health, Amar, where is Amar? Amar, we'll need to sit for some time. There's a lot of things planned. In fact, even in the current year's budget, we are planning a lot of things. So we'll sit sometimes, but let me suffice to say that we're really trying to take doctors, diagnostics and drugs right up to urban. And last year too, in our budget, we earmarked something like 110 crore rupees only for urban health and not for brick and mortar structures at all. It was only for functionaries, because we felt that the density of, in urban areas, the number of ashas to the population was always much less, or the number of ANMs to the population was always much less than rural areas. And so rural areas did much better compared to urban areas, and the worst performing pockets were urban slums, then came rural areas. But even in rural areas, probably the ones that are really at the bottom of the pyramid are the farm workers. You have these farms, and there are farm workers who come from different districts. Now, in most places, you don't have the farm owner, the farmer themselves doing agriculture. So if you have Kachhi Kampas in Sabarkantha, or any of the people from the Patel community, or any community, usually they have tribals coming from places like Dahod, Panchmahals, Arvali, etc. as farm labor, and they're all scattered, so they live on these farms, and so reaching out to them, providing medical services is probably another challenge. Equally bad or equally a big challenge for us is urban slums. So we are really looking at a bunch of things this time. We've given them human resources, as I said last time. Now using TECO and all these treatment pathways, drugs, diagnostics, doctors, we'll actually do something very, very interesting to reach out to all of them, and with this triangle getting inverted. So all this is a part of the things we plan for urban health. And then last, Gunjan had a question about geriatric clinics, whether we need separated special clinics for geriatric patients. We have a policy in government, and I think Dhurake Sahab has also been instrumental in implementing it. The idea again is not to create another silo, another separate. But then within hospitals, one of the decisions we've taken is that there'll be a separate queue for elderly patients. And then one more thing that government has recommended, and this year we will be implementing, is also to earmark a certain number of beds for geriatric cases, and also for people who need some hospice care, etc. So these are also things on the card. And again, there are two different, should we have a vertical thing or an integral, inclusive things? Because sometimes, again, having a separate hospital for the geriatrics may not be such a good idea as integrating it. You can have a separate geriatric ward. I saw an excellent example of this in Godhra. Recently, I visited the civil hospital Godhra. There's a separate geriatric ward there as a part of the general hospital. And I've interacted with the people there, with the patients or the people in those wards, and it was very heartening to see that they're all taken very good care. So, I mean, all these are efforts which are going on. And finally, Continuum of Care in Government, Arun, right? So this is definitely there. And you also spoke about evidence-based decision processes, isn't it? We're working very strongly on this. As we said, not just in TACO, but in many other, we're collaborating with Stanford University in a very big way to do this. And we're looking at maternal health and various other parameters. And similarly, Harvard University too has got involved with us in terms of mental health. So there's there's an outstanding professor there called Dr. Vikram Patel. I don't know if you've heard of him. He's one of the stars in mental health. So we're working with them as well. So the idea of all this is to look at how evidence-based decision-making can be incorporated in our normal work. So this, I think, thank you for a very long
So, thank you so much once again, ma'am, for enlightening us on various initiatives which Government of Gujarat has taken and will be taking in the coming future about addressing many of the public health issues. So we break for tea and then we come back in 10 minutes.